Hey everyone, welcome to the MMOA podcast. My name is Kay Mayordomo, and I'm a home health physical therapist and a coach for older adult fitness classes. Today, I want to continue with part 2 of 3 of a home health case study I shared when I was on the MMOA podcast last month called Independent at 98. If you haven't listened to part 1 yet, I would definitely recommend going back and listening to that episode because I go into depth with the background of this patient's initial presentation, his falls, his confidence levels, and his goals. To give you a quick recap, this patient is a 98-year-old male who lives at home alone with a caregiver, and his goal was to become independent again with no caregiver. Prior to returning home, after his 3 falls, he spent 5 weeks at a sniff, and we left off with the patient gaining more confidence and asking me to make things harder. And this episode will be more on digging into what factors will continue to contribute to his independence. So we're going to be talking about starting the conversation of what independence looks like to him, and then going into floor transfers and falls preparedness. So we revisited what independence looks like for him and asked him what the caregiver actually still helps him with, because independence for him was probably not going to be all or nothing just yet. He didn't need to go from needing a caregiver to suddenly doing everything completely independently. So we started to break down the specific things that were still a challenge for the patient, because he had difficulty reaching the shower head with his right hand while maintaining balance. So he still needed help with showering at that point because he just didn't feel confident with it. I think the cool part about home health is that we know the exact scenario we need to work on in the patient's home rather than having to just imagine it in our heads in an outpatient clinic or at a SNF. And then I also asked him what it looks like for him to prepare his own meals and whether he felt confident with that. When we first started, he said he didn't want an OT. And we decided that for right now, he can pretty much ask his caregiver to slowly take back some of those tasks. He said usually for breakfast, he eats cereal, and usually for lunch, he eats a sandwich, and dinner is pretty light for him. So he wasn't too intimidated by the fact that he was going to have to return back to preparing his own meals. So the last thing he said was that he had trouble putting on his compression socks himself. So we discussed that a compression sock aid could be helpful so that he can practice with that, so that he can eventually do it on his own. So when the patient started with me, there's no way he was willing to work on getting on the floor himself, or even with my help, no matter what I said. So part of what built the confidence was telling him which measures he improved upon. So when we retested the 30-second sit-to-stand test, he still scored 0 on the official test, but now he could do more reps with his hands, and that's progress. So I got to tell him, look, when we first started, you were able to do 5 reps with your hands in the 30 seconds I gave you, but now you can do 8 reps, which shows that you've improved. So we have to be the ones to show the patient the progress, and that really helped him trust the process, even though he wasn't where he wanted to be just yet. So once he started to get stronger and more confident, I started to think, let me pitch this idea and start small in terms of floor transfers. So I pitched the idea and explained why it's important for being independent. Pretty much because there wasn't going to always be somebody around to help him up. He said that usually his neighbors help him up, but I gave him a few what-if scenarios, and he agreed that it would be good to work on floor transfers. So we started from standing to a partial kneel onto the floor, but we brought the ground to him first because he wasn't ready to go all the way onto the floor just yet. And that was definitely the right amount of intensity. We got a baseline of how long it took him to do 5 knee-to-pillows on one side, and we're going to use that as his baseline data. So we started from standing to partial knee onto the floor, and he had to put his hands on the armrests to help him get his knee down. But once he got his knee down, he felt good, but we had to stack like 4 pillows to get started because it felt too challenging to do it all the way to the floor. So there's a recent 2026 pilot randomized trial that found that even a short floor rise training program could improve people's ability to get up from the floor and their perceived ability to manage a fall. And that second part is so big. The perceived ability to manage a fall, that means their confidence in the skill got better, which is so important because besides just training the physical task of getting up from the floor, we were continuing to train that confidence piece after having 3 falls in a short amount of time and really helping the patient see that he doesn't always have to call his neighbors to help him. Lastly, we discussed the other parts of falls, which is how to fall. We usually don't start here. We usually start from the top down, which is why we started with the floor transfers. But this is the other piece that is equally important. We aren't just ignoring the fact that sometimes a fall is inevitable. If we miss a step or something comes unexpectedly at us that causes us to lose our balance, we need to be ready for that. So the first, before he went to the sniff, he avoided any serious injuries with his 3 falls from last year, but I wanted to make sure that continued to be the case. So when people say, hopefully you don't fall, that's not helpful. Someone once told me that hope is not a strategy. So one of the things we started practicing was a backwards fall, focusing on tucking in his chin, slapping the ground, which in this case was his bed because we started from an elevated surface, and distributing the forces of falling from his bottom through his back so that not one part of his spine was taking all of the force. So instead of just saying, hopefully you don't fall, we focus on teaching him a technique and a strategy that could save him from having a serious injury. So we started with him just seated on his bed and just teaching the different components of the chin tuck and then slapping the ground and kind of rolling from his bottom to his back. And then he felt comfortable. I showed him what the next progression would be, and he said he was comfortable trialing that other progression or like the progressed version. So then he also was able to try standing to seated onto his bed and rolling back. And that didn't seem bad. I told him he needed to focus on just getting his butt as close to the bed as fast as possible, pretty much, so that he wasn't spending a lot of time in standing and possibly hitting his head on the way down. So those were the 3 things that we continued to work on. He still had his exercise program of sit to stands, deadlifts, and some marching and heel raises. But we roped in the caregiver a little bit more because the caregiver was just kind of reminding him of what his exercises looked like. But the patient was pretty independent with what I've given him. But now I have the caregiver really trying to have him do as much as possible for when he's in the shower and trying to get the shower head, and also supervising him when he works on the backwards falls onto his bed. So the home exercise program doesn't always have to look like just straight up exercises, just straight up AMRAPs. We can kind of start to tie in all of these things that we're working on, but in a safe, controlled environment. So if there's a version of something you've worked on with the patient, something is better than nothing in terms of giving them something that's similar so that they can work on the pieces of that. So for example, like the falls preparedness and the falling backwards, I told the caregiver that he could start with the patient just sitting on the bed and then just rolling back. And if the patient felt comfortable doing the standing to seated to rolling back, then they could work on that as well. So when I think back on this patient, I think the biggest takeaway for me so far is that independence wasn't just about getting stronger. It wasn't just improving balance. It was about figuring out what independence actually meant for this patient and then working on the specific things that were still keeping him from doing those things on his own. We worked on slowly taking back tasks from the caregiver, building his confidence through measurable progress and telling the patient about those measurable pieces, and eventually challenging him with things like floor transfers and falls so that he would be ready for it. Even though he wasn't willing to try it at first, it's good to kind of check back in when the patient is feeling more comfortable about things to see whether they would start or feel ready to do it. So we discussed what to do if a fall actually happens, because hoping someone doesn't actually fall isn't really a strategy. And I think that's one of the biggest roles we have as physical therapists, is helping people feel capable of managing the things they're afraid of, not just making them physically stronger. Because at 98, the goal wasn't necessarily to make him invincible or eliminate every risk. It was to give him the strength, the skills, and the confidence to keep living his life as independently as possible. And honestly, I think that's what good home health physical therapy is about. We get to meet someone where they're at, whether that involves a lot of functional issues, a lot of fear, really figure out what matters to them, and then helping them realize that they may be more capable than they initially thought. And we have a little bit more to work on with this patient. So I'll catch you on part 3 for the last series the next time I'm on this podcast, where we discuss the last bits of his case. So make sure to check out the MMOA Digest, where you can stay up to date on all things geriatrics. All right. Thank you and have a good week, everyone. Bye.